Associate Professor of Medicine at Cooper Medical School of Rowan University in Camden, New Jersey. He's a member of the Division of Infectious Diseases and Hospital Epidemiologist at Cooper University Hospital in Camden. He's been a senior medical consultant for the Camden County, Southern and New Jersey Regional Chest Clinic since 2001, and is a founding member of the State of New Jersey TB Medical Advisory Board. He's also an attending physician in the Early Intervention Program, the Comprehensive HIV Care Clinic at Cooper University Hospital, and has interest in the management of HIV and TB co-infection. And he'll be talking to you today about HIV and TB.
All right, so thanks for having me down here. I'm from Camden, which if you've sort of try and project your experiences, I think there's too many microphones here. If you're trying to project your experiences from Baltimore and from Chester, Camden is very similar to both of those places, except probably poorer, okay? Camden, I think, is still considered to be the first or second poorest city in the United States and has the highest crime rate. However, it also has many other interesting features that we'll be talking about. So my area of expertise, I'm an infectious disease specialist. I have significant interest both in HIV disease, but also in tuberculosis. And what I'm going to be focusing on today, and these are some of the reference materials, what I'd like to be focusing on today is talking about TB and HIV co-infection, okay? And I know that there is a wide diversity of how much medical background some of you have a lot more, some of you have less. But I'm going to focus a lot on the epidemiology of TB and HIV co-infection. I'm going to talk about the global epidemiology, but I'm going to bring that home to what we're actually seeing in our communities in the United States. I'm going to talk about the impact of these two diseases on each other and some specific management issues. And then at the end of my talk, I'm going to talk a little bit about multi-drug resistant and extremely drug-resistant tuberculosis, which is sort of a new and evolving global catastrophe. Okay, so first of all, if you learn nothing else from this talk, it's important that for those of you who don't have a lot of TB background, that you understand the difference between latent tuberculosis and TB disease, which is a topic that no matter how often I lecture on tuberculosis and what level the audience, people still can't get it straight, okay? And it has a tremendous difference to us in terms of what we're talking about, okay? So these are some terms that we're going to be talking about: latent tuberculosis and TB disease, and primary and reactivation tuberculosis. And we'll be talking also about tuberculin skin tests, or the PPD, and we'll be talking about the new blood tests that we use to diagnose tuberculosis infection. And some of you are familiar with the term DOT and DOTS, which are directly observed therapy. And the DOTS is a more comprehensive approach to directly observed therapy, as well as a lot of other things that are done globally to ensure for treatment of tuberculosis. All right, this is interactive, so feel free to interrupt with questions at any point. There are also a number of questions that are in here that are basically there to use as discussion points for some of the things we're going to talk about. All right, let's start with this clinical vignette. All right, this is a woman who presented to our tuberculosis clinic in Camden. She was discharged from one of the local hospitals with a new diagnosis of smear-positive pulmonary tuberculosis. And she was discharged on 4-drug therapy using the standard 4 first-line medications. And what we know about her is that she was from South Africa, been living in the United States for about 2 years with her husband and her 11-year-old child. And she really comes with no medical records from her arrival to the United States, so presumably she's undocumented. and she did not have HIV testing performed as part of her hospital stay. So she comes to the clinic, her HIV status is unknown. So should she have HIV testing performed as part of her TB evaluation? Okay, and we can do this with, who likes answer A? Okay, who likes answer B? Okay, how about C or D? Anybody like C? C is basically that you don't need to do it, and D is you can do it, but it's not going to help you at all with managing this woman. All right, so everybody likes A or B, okay? All right, and that is in fact, I think most of us now believe that B would be the correct answer. HIV testing is part of the standard of care for management of all tuberculosis cases, and depending on what state you live in New Jersey and I believe in Maryland, it's opt-out testing for HIV. So there should be no barriers to doing HIV testing in this circumstance. And it really, as I will show you, is a critical part of their management as you go through and treat their tuberculosis. All right, so here's the second question. Based only on what you know, this woman's from South Africa, she's been here 2 years, what is the likelihood that she'll be HIV positive? All right, less than 5%, 5 to 20, 20 to 50%, or more than 50? All right. Okay, so we have a mixture of C's and D's. Okay, so let's take a look at this map. This is the global TB incidence map. This comes out, the World Health Organization updates this every year. This is the 2011 data. The 2012 data will probably be out in another month or two. All right, and you can see that this goes by color. Let me, is that correct here? All right, don't know if this is necessary. Here we go. All right, so the darker the blue, the higher the incidence of tuberculosis, okay? So when we talk about incidence rates of TB, we talk about rates in terms of cases per 100,000 per year, okay? So here we are in the United States. We are a low TB incidence country. The rates continue to drop in the United States. We have 3.4 cases per 100,000 of tuberculosis each year, okay? And you can look, if you look at this map, Western Europe, North America, Australia, and parts of the Middle East are all considered to be low TB incidence places. All right, we in the United States look at Mexico and say, oh, they have so much TB there, their rates are terrible. Their rates are about 3 or 4 times higher than the United States, but they're still classified globally as a low incidence country, okay? If you move down here to sub-Saharan Africa, you're talking about rates of greater than 300 per 100,000 per year. If you move down to Botswana and South Africa, those rates are about 1,000 cases per 100,000 per year, or 1 in every 100 people in those countries has tuberculosis each year. So those are enormous compared to what we see in the United States. And why does that become important? Because these people leave their countries and come to the United States. Okay? And when you migrate to the United States, you bring with you your tuberculosis risk from where you were born and where you may have been exposed to tuberculosis. Okay? All right, so this is the HIV map. You've all seen this map before as well. Excuse me 1 minute. And these are the HIV rates. This is about 2 years out of date. But you can see that global prevalence of HIV infection differs greatly in where you are. And again, moving into sub-Saharan Africa, you're dealing with rates that are significantly higher than the United States. Up to 30% of individuals in some of these countries are HIV infected. Okay? If you overlay those 2 maps that I just showed you, this is the estimated HIV prevalence in new TB cases in the world. And you can see that in sub-Saharan Africa, more than 50%, and in some of these countries, 80% of new tuberculosis cases are HIV co-infected. okay? So it is a huge problem. Whereas you get back to the United States, it's about 7% of new tuberculosis cases are HIV co-infected. So getting back to our woman, all we know is she comes from South Africa, just playing the odds, well over 50% chance that she's going to be HIV infected, okay? All right, does it matter that she's HIV infected? Well, it actually matters a great deal. This is, again, data from the World Health Organization, and this is data for mortality and successful treatment if you are HIV positive or HIV negative and have tuberculosis. So what do you want to see here? HIV negative are the orange bars. This is successful treatment. In all instances, if you are HIV negative, you're more likely to be successfully treated for your tuberculosis. This is international data, and I'll show you US data in a bit. And this is mortality data. If you are HIV positive, you are 4 times more likely to die of your tuberculosis during the course of treatment than if you are HIV negative. So it makes a tremendous difference if you're HIV positive, okay? All right, so just taking a step back, where do we stand globally with tuberculosis? This shows you the TB incidence and TB death rate, both for HIV positives and HIV negatives, over the last 20 years. And you can see that finally, the tuberculosis rates globally have begun to decline, okay? In most continents on the United States, except for Africa, these rates were all declining going back 10 or 20 years ago. But in sub-Saharan Africa, these rates were continuing to climb until the last couple of years. And now globally, these rates are decreasing everywhere. And this is due to tremendous amount of effort from all kinds of global philanthropic organizations, from the World Health Organization, and tremendous efforts to try and treat TB and the TB-HIV co-infection. However, you have to take a step back and look at how many people in the world are infected with TB. Now remember, we're going to distinguish between TB infection and TB disease. TB infection is people who have breathed in tuberculosis germs, but they're not necessarily sick. And about 1/3 of the world's population are TB infected. Of those people, each year in 2011, there were about 9 million new tuberculosis cases, and about 13% of them were HIV co-infected, although we've already talked about these areas in sub-Saharan Africa where those percents are 80% and higher. There were 1.4 million TB deaths in 2011, and about 430,000 of them were HIV positive. Globally, about 1/4 of HIV-related deaths are due to tuberculosis, okay? However, the good news is that TB cases, TB mortality, even in HIV positives, is falling globally, and we are seeing significant progress being made. All right, so let's take a step closer to home. This is US data. I've shown you some rather astonishing numbers for global. This is US data. TB is a rare disease in the United States. Okay, you can see that tuberculosis was on the decline going back into even the middle of the past century. And TB cases were declining a long time ago, well before the introduction of some of our new tuberculosis drugs. Then you can see this hiccup here in the late 1980s and early 1990s. And this hiccup was due to 2 things. It was due to the HIV epidemic in the United States and the fact that the public health infrastructure that had been built up to deal with tuberculosis back here had kind of disintegrated. TB kind of became a forgotten disease. A lot of the tuberculosis health clinics really were no longer operational, and all of a sudden there was more TB than we knew what to do with, and case rates went up. Now, a lot of that public health infrastructure was rebuilt, and a lot of the current principles of directly observed therapy stemmed directly out of this blip in tuberculosis in the mid to late 1990s, and ever since then, cases have continued to decline. The numbers for tuberculosis come out each year on World Tuberculosis Day, which is usually March 24th each year, and it actually commemorates the day that Robert Koch, who's famous for Koch's postulates, first reported on the identification of tuberculosis. So each year on World TB Day, we get our new numbers for the year. And you can see that the preliminary 2012 data is we actually have less than 10,000 cases of tuberculosis in the United States. That's an astonishing figure and a very low figure. However, the fewer cases you have, the fewer experience people have in recognizing and dealing with tuberculosis. So the downside of less tuberculosis is that people are less likely to recognize it, and they're less likely to treat it properly because they don't have the experience, okay? All right, the other important trend in tuberculosis is that about 10 years ago, the number of foreign-born cases reached about 50% of cases of tuberculosis in the United States. And now in 2012, 63% of tuberculosis in the United States is in individuals who are foreign-born, okay? So we've done a good job of eliminating tuberculosis among people born in the United States, but there's always going to be tuberculosis from people who come from elsewhere. All right, any questions so far? Okay, this is 2011 state data, okay? So these are tuberculosis rates. Here, being a blue state is a bad thing, okay? Because a blue state is a state where your rates are higher than the average for the United States. And you can see I come from a blue state, as do most of you, okay? And the features that most of these blue states have in common is they are states with high levels of immigration, okay? So if you look at the big white states in the middle, those are states that just don't have as many foreign immigrants in them. Whereas all of these states on the borders and in the Northeast are states that have large numbers of immigrants. Maryland is a high state. New Jersey is a high state. Okay, Washington, D.C. is a very high state. Traditionally, it's actually not a state, but traditionally has had among the highest rates in the has had the highest rates in the United States for many years, although not as high as they used to be. Okay, so all right. So what about we were interested in co-infection? So these are the co-infection rates, and you can see back 20 years ago, those rates were much higher. If you look at, again, 2012 data, about 8% of TB cases are co-infected, okay? Those numbers are higher, however, if you focus on the age 25 to 44 age group, which is sort of the peak HIV incidence group, or traditionally has been the peak HIV incidence group. All right, now I showed you global data that says if you're HIV positive, you don't do as well with tuberculosis. This is US data that shows you exactly the same thing. The numbers are smaller, but if you just compare this curve here, which is all people who have tuberculosis, and compare those to those who are HIV infected, which is this dashed line here, even though the mortality has declined in HIV co-infected individuals, and this represents the introduction of highly active antiretroviral therapy in the late 1990s, you can see that the mortality difference for HIV uninfected and HIV infected is fourfold, just like it is in the rest of the world. So if you are co-infected, you are not as likely to do as well with your tuberculosis, even in the United States, same as the rest of the world, okay? All right, now the one thing we have become much better at, this just shows you number of people with tuberculosis who actually get HIV tested. And you can see that we are now over 75%. We used to actually not be very good. We were more in the 50 to 75% range. But we've become much better at making sure that everybody with tuberculosis is tested for HIV disease. And you can see parts of the world are very good about that, and other parts are not very good. Look at China and India, where if you actually add up the number of cases, probably half of the global burden of tuberculosis comes from these countries, and we really don't have very good ideas about how many people are HIV co-infected with tuberculosis in those countries. All right, so who is at risk for both HIV infection and TB? A lot of people. I mean, we know that there are certainly some high target populations like injection drug users and the homeless, people who are incarcerated. However, both of these are diseases of lower socioeconomic status, okay? And it's a lot of people that we see are individuals of lower socioeconomic status. Both HIV infection and TB spread more commonly in lower socioeconomic communities. And let's talk a little bit about immigration. We know that rates of tuberculosis in HIV individuals in the United States are declining, mostly because it's tough to catch tuberculosis in the United States. However, we have lots of immigrants in this country, some of whom come from countries of higher TB prevalence, and we know that there is spread of HIV disease in certain poorer immigrant populations. In New Jersey, we deal with a lot of HIV disease in our migrant farmer population. We have lots of single men from Mexico and Central America who are newly HIV infected and spreading HIV disease. And a lot of those also are co-infected with tuberculosis. So if you have to look at your populations and think about who might be at risk. All right, so where do people with tuberculosis in the United States come from? Well, the biggest category here is everywhere, okay? People come from all over the place. A lot of our cases, and this just reflects immigrant patterns, come from Mexico, from the Philippines, from Vietnam, but from all over the world. And in our HIV clinic at Cooper, we actually have individuals from all of these countries that we take care of in our HIV population. Now, one thing that traditionally HIV clinics have never been very good at is tracking country of origin of the individuals that they take care of. We know that we see global clientele, but we never really had good numbers for where all those people came from. This is data that actually was just recently published this past year, looking at new HIV cases in the United States from 2007 to 2010. And of the newly diagnosed HIV positive individuals, 16% of them were born outside the United States. That's a lot of individuals. And some of these are places that we know TB case rates are very high. A lot of folks from Africa, a lot of folks from Central America and South America, where we know that the TB case rates are very high. So it's not surprising that we continue to see tuberculosis in our HIV population. Okay, so just to summarize what we know about testing, we know that HIV testing should be done in everybody who is diagnosed with tuberculosis. The CDC recommendations are that they should have HIV testing at least by the time you start them on TB therapy. And if they're positive, you want to know what their CD4 count is. And we'll talk about why in a minute. All right? The other thing that's equally important is if you are evaluating people for latent TB infection. Okay? And again, latent TB infection is not TB disease, and we'll talk about that in a second. It's important to know their HIV status, because the single greatest risk factor for progression from latent to active disease that we know of is HIV infection. So if somebody has latent TB infection and you're trying to decide whether or not they should be treated, you obviously would treat them if you knew that they were HIV positive. So you really should be considering that as part of your evaluation of everyone you see and evaluate for latent tuberculosis. All right. Any questions on the epidemiology so far? Yeah.
I don't know if this makes any difference, but is there any way, or do we know, are you saying that people come here already with the diseases, where they're some of that and some of that they're more at risk for getting it because they're in a novel?
Well, there's a couple of different issues. All right. In terms of tuberculosis, people are latently infected with tuberculosis, and then they come to the United States. And they have lifelong risk of tuberculosis becoming active, but then things can happen like HIV disease that increase their risk. HIV disease, some of these people are infected in their own countries. HIV care is much worse in many places than it is in the United States. But HIV disease is also something that is transmitted in some of these poorer immigrant communities where they don't have the same awareness or understanding of HIV prevention. So I think it's a mixture of both of these things. All right, so let's just talk briefly about HIV disease and what does HIV do to tuberculosis and what does TB do to HIV disease. All right, and in order to understand this, let's talk briefly about the natural history of tuberculosis. So tuberculosis occurs when somebody who has never seen TB before breathes in some tuberculosis organisms. And those organisms settle in their lungs, and they set up housekeeping, and they multiply, okay? And then they get these foci of tuberculosis that eventually your immune system controls, okay? And that happens to everybody. And how do we know if somebody's been infected? They have a positive tuberculin skin test or a positive IGRA assay, which is the one that we're going to be talking about as the quantiferon test, which is a blood test that measures tuberculosis. So if you've never seen TB and you breathe it in, those organisms replicate because your immune system isn't very well adapted to them, and then your immune system learns and controls things, okay? So about half of your lifetime risk when you first breathe in tuberculosis germs, about half your lifetime risk of getting sick with tuberculosis occurs in those first couple of years, okay? Because your immune system's not real adept and has to learn a little bit. Some people have genetics that are not quite as good, and there's all kinds of differences in genetics that make some people more susceptible to get sick. If your immune status is weakened, then you're more likely to get sick. And there are some tuberculosis strains that are more virulent. If you get through those first couple of years and your immune system contains the tuberculosis, it becomes dormant or latent. However, you then have a lifelong risk of reactivation occurring and becoming sick again from tuberculosis, okay? And that's a small risk, but that risk persists throughout the rest of your life, okay? You can also get reinfected with tuberculosis. Now, it doesn't happen much here because there just aren't that many people sick with tuberculosis who are going to come up and cough in your face. And if you have an immune system that recognizes TB, meaning you have a positive skin test, then you're pretty good at preventing yourself from getting reinfected because your immune system's going to jump on that and kill those new tuberculosis germs. But you're still at risk for your own germs that are already in there dormant eventually becoming active, okay? Does that make sense? So that's the natural history of TB. All right, so when you're TB infected, your immune system produces all kinds of cytokines to try and control the infection. Now, these cytokines are things like tumor necrosis factor and IL-1, and what they do is they help you kill mycobacteria. But at the same time, they rev up replication of HIV. So if you have active tuberculosis, your immune system's working overtime, and it actually helps your HIV replicate more, okay? Now, the other way around, as your HIV infection takes over, it lowers your CD4 counts, it lowers your T cells, it decreases production of these things, and it keeps you from controlling tuberculosis. So on the one hand, TB revs up HIV infection, and on the other hand, progressive HIV infection impairs your ability to control TB, okay? And a normal person makes these things called granulomas. Granulomas are basically scar tissue that encase TB germs. When you have advanced HIV disease, you don't make granulomas. You can't encase those organisms, and they can disseminate and spread. Your risk of progressing from latent to active tuberculosis, if you are HIV positive, is about 7 to 10% per year, okay? Your risk of developing progressing from latent to active tuberculosis if you're HIV negative is 5 to 10% in your entire life, okay? So you can see that is a huge risk for progression. And it is by far the single strongest risk factor that we know. And this occurs early, all right? As soon as you are HIV infected, that rate goes up. Doesn't jump 100-fold, but even within the first year of being HIV infected, your risk of progression from latent to active tuberculosis doubles, okay? Now, many of you have seen this slide before. This is the natural history of HIV. You get infected with your primary infection here. Your T cells dip a little bit, then they go back up, and then slowly over years, your CD4 cells decline. Your virus load goes up initially and then drops down again and begins to climb over years. However, your risk of tuberculosis begins to go up very early, okay? It doubles in that first year, and then as you get to very advanced HIV disease, it's more than 10-fold, some people would say 50-fold higher risk of tuberculosis per year when you get to advanced HIV infection, okay? So that's why when you have a country that has a lot of tuberculosis prevalence and a lot of HIV, there's going to be a lot of co-infected individuals. All right, and again, just to put the numbers in perspective, advanced HIV infection is by far the single strongest risk factor for progressing from latent to active tuberculosis, okay? Much higher. In the TB clinics, we all worry about contacts of new cases because those are our high priority populations. HIV is a stronger risk factor than being a contact of an active case, okay? All right, so what happens if you find these people who are HIV co-infected with latent tuberculosis? If you put them on medicine, can you reverse this? And the answer is yes. Not completely, but significantly. And most of these studies come from Africa, but they come from other countries as well. As soon as you put somebody with HIV infection on antiretroviral therapy, you decrease their risk of developing tuberculosis if they're one of those individuals who's latently infected, okay? That risk drops between 50 and 90% in the first couple of years, and it correlates with the increase in CD4 count. So one of the best things that you can do to prevent tuberculosis in parts of the world where there's lots of TB is to put people with HIV disease on antiretroviral therapy. Now, you can't completely eliminate their risk, but you can significantly decrease that risk, okay? All right, so when we see TB disease in people who are HIV infected, we see a couple of different things that happen. One is that people who get newly exposed to TB are more likely to just progress and get sick, okay? You are also going to see more reactivation disease in people who are latently infected. What you're going to see depends on where you are. If you happen to be in Botswana, where there's plenty of tuberculosis, where you're likely to be exposed to people with TB, both of these things are going to happen commonly. If you live in the United States, where there's very little chance that somebody's going to come cough on you and give you tuberculosis, most of the disease that we see is reactivation disease in people who were latently infected previously and now have HIV, and their immune system loses its ability to control it. Okay? All right. The other problem is that TB disease in HIV doesn't always look like what we think TB should look like. All right? If you have high CD4 counts, your TB disease looks like what it's supposed to in general. Okay? It looks just like the TB disease we see in everybody else. Occasionally, we'll see some more extrapulmonary disease and occasionally some unusual manifestations. But most of the time, they look like regular tuberculosis. However, as your CD4 counts drop, TB disease looks different. We start to see all kinds of extrapulmonary disease and disseminated manifestations, and it becomes a much more lethal disease, and it also is a harder for us to recognize disease because it doesn't look like TB. We don't see people with big cavities in their lungs and say, oh yeah, that's TB, I know what that's supposed to look like. We see people who present with things that look like bacterial pneumonia or look like PCP pneumonia. And if you don't know they have TB, you're going to miss the diagnosis. Okay? So the X-rays, as your CD4 counts drop, can become very atypical, and they can even be completely normal, and people can still be infectious and have cultures from their sputum cultures that will grow tuberculosis. Because of this, we're not so good at recognizing TB in advanced HIV disease. It leads to delays in diagnosis, delays in treatment, and contributes to that higher mortality that we talked about earlier, that if you're HIV positive, you're more likely to die if you have tuberculosis. Okay, these just show you some unusual manifestations. This is somebody who's got lots of enlarged lymph nodes in the chest. This is somebody who's got something that looks just like a regular bacterial pneumonia. This is actually one of our patients who had a T-cell count in the 250s. This was one of our Mexican day laborers who we had a lot of trouble getting into care. And you can see he's got diffuse infiltrates throughout his lung field. You know, if you didn't know that that was tuberculosis, you would miss the diagnosis. Okay, so let's move on to our next vignette here. So this is a 48-year-old homeless man in Camden who has HIV testing done through one of our outreach vans, and he's found to be HIV positive. He agrees to have a CD4 count done, but really doesn't agree to any other testing. He looks well. His T cells are 138. Okay? He refuses to come to the HIV clinic. For whatever reason, he does not want to come to the HIV clinic, but he does agree to get a TB test done. And it turns out that the reason he agreed was because when he was little, his mom had TB. Okay? So TB is something that he recognizes and knows that he doesn't want to have. All right? So how do we evaluate somebody who's HIV positive for tuberculosis? Okay, what testing tools do we have? So we have a couple of options here. We have skin testing with the tuberculous skin test. And if you're going to use a skin test, the cutoff is 5 millimeters, okay, instead of the normal 10 millimeters or 15 that we use to read a positive test. And we'll talk about IGRA assays in a minute. Or can you use either of these, or should you do a chest X-ray or symptom assessment? What should we do for this guy? Okay. I think that, in fact, the answer is, yeah, pretty much anything, any and all of the above. There is no perfect test for tuberculosis. And finding both active tuberculosis and latent tuberculosis in people who are HIV infected, especially when their CD4 counts are low, requires use of a variety of different tools. All right, so let's talk about the skin test, okay? The tuberculin skin test, or PPD, is a traditional case-finding tool for tuberculosis and a screening tool that we've used for many, many years. The criteria for a positive test, if you're HIV positive, is 5 millimeters. And the reason why the criteria is set lower is because we want to try and pick them up. The problem is that even at that lower cutoff point, if you have a low CD4 count, your skin test is likely to be negative. All right, the other test that we have is the IGRA assay, or interferon gamma release assay, which is a blood test. And we like it because it's a blood test. They get it, they get the blood drawn, and you get a result. They don't have to come back 2 days later and not show up and not get their PPD read and then have to do it all over again. Okay, there are 2 IGRA assays that are in use. One is the quantiferon test, and the other is the T-spot test. These tests are better tests in some ways, but they are also not perfect tests. All right, they're helpful in the general population because people who have had BCG vaccine do not have positive IGRA tests. Okay, and we all see lots of folks who come from countries where they've gotten BCG vaccine. These tests do not come back as positive if your only exposure is from BCG. Yeah. Okay. BCG is a vaccine that is given in large parts of the world to prevent overwhelming tuberculosis in childhood. Okay. If you look at pretty much any place other than North America, Western Europe, and Australia, BCG is given to infants. In some countries, it's given at 2 months. In some countries, it's given at older ages. And the problem is that it can give you a false positive tuberculosis skin test. If you have and people who come from countries where they get BCG always believe that their skin tests are due to BCG. They refuse to believe that they're due to exposure to tuberculosis. So for us, one of the advantages of these blood tests is you don't get a false positive from BCG. Okay? Yeah?
Did we use BCG in the United States at one time?
BCG was used in some pockets in the United States, but it was never universally used in the United States. There are some studies that were done in Alaska, in Alaskan natives, and it does have a protective effect. The problem is if your incidence of tuberculosis is low, there's no benefit to giving BCG vaccine. And that's why low prevalence countries don't vaccinate. And some countries are changing their policy, but many countries still do vaccinate. Okay, so we like the IGRA test for a number of different reasons, and it's basically a blood test. Now, the 2 tests, one is called a T-spot test, because you actually count spots, okay? You look at, and we don't actually do this, it's sent off to the company, and they count the spots, okay? And you have a positive control, and then these are your test assays and a negative control. And for a test to be positive, you have to have a negative control, a positive control, and a positive test, okay? If you have a negative positive control, then the test is indeterminate. And that can happen when people's immune systems are weak and they can't produce interferon gamma, which is what we're reading in these tests, okay? The other test is a quantiferon, and again, it's read the same way. There's a negative control, a positive control, and a TB well, okay? However, unless all of these fall in according to plan, a test may be uninterpretable. So we see it in a lot of people with low CD4 count, we see that these tests are indeterminate because they don't have enough interferon to produce a positive test. Okay? So what do we do in HIV positive? Do we do one or the other, or can we do either? And the CDC says you can do either, okay? Because neither is perfect. From a practical perspective, most HIV clinics have switched to a blood test. All right, and that's because most of us are dealing with populations that have low rate of return to have their tuberculosis skin test read. However, even though most of us seem to believe that the IGRA tests are better, that's never really been proven that they're actually better. And we've actually seen more problems with false positive IGRA tests over the years than we have with TB. So neither of these is a perfect test. All right? So this is what the CDC says. If you have groups with low rates of return or history of BCG vaccine, you're going to use this test. If you're under 5, you still have to use the skin test because the other tests aren't validated. However, in most instances, they're interchangeable. We generally don't do both for everybody, one or the other. All right, so what, yes?
How do you know if your IGRA test is a false positive?
How do you know if your IGRA test is a false positive? That is a big problem because they're not supposed to happen and they do. In fact, there was I think it was about a year ago, there was a national recall when several batches of quantiferon tests came out as positive when in fact it was all laboratory testing issues. So even though we were hoping that these IGRA tests would be perfect tests, they're not. They're mediocre tests that you have to be cautious about how to interpret. I'll show you a slide in a second that sort of gives you the information that makes us all crazy when we look at these tests. Yeah?
Reports of the way that you actually prepare when you obtain.
Yeah. There are logistical problems with the way that the tests are collected and processed that do impact on the results. Now, the newest versions of the test, the in-tube test, is supposed to have fewer issues, but I think there are still issues with them. Okay? All right, so, yes?
Some of the results that we're getting back now actually have in there that they are stating that there's a possibility of a false positive with other mycobacteria, atypical mycobacteria.
Right. There are a couple of other species. Luckily, MAC is not one of them, which would be the most common thing that we might see in our HIV positive population. But some of the other mycobacteria do give a false positive, and depending on where you are geographically, that can be an issue. So what we basically do, if somebody is newly HIV diagnosed, they get tested for tuberculosis, but they also get a symptom assessment. Okay? If they have no symptoms and a negative test and a good CD4 count, you can say, okay, they probably don't have latent tuberculosis. Okay? If they have no symptoms and a negative test but a low CD4 count, you really can't say that. Okay? And we'll talk about that group in a minute. If they have no symptoms and a positive test, you have to evaluate them for active tuberculosis. If they don't have active tuberculosis, you treat them for latent disease because we've already defined them as people who are at very high risk to progress from latent to active disease. All right? And if they have symptoms, you're going to evaluate them no matter what. Okay? And if they're contacts of an infectious tuberculosis case and they're HIV positive, you're going to treat them no matter what, even if they've been treated before, all right? Because these are people who theoretically can be reinfected, all right? And this algorithm, I think, is in the handouts that you'll get. All right, so we talked about these people with CD4 counts less than 200. We consider them to be TB status indeterminate because our tests aren't good enough to say that they don't have TB. So you definitely want to retest them when their counts are higher, but even if you're not retesting them, you want to continue to do symptom assessment in those populations. Now, we don't know how often people should be retested, and the other thing that we don't know is should we really be treating immigrants from high TB incidence countries the way that they're treated in their own countries. If you are newly diagnosed with HIV in South Africa, you are treated for latent TB disease, no matter what, because so many people have latent TB disease that that the WHO recommends treat them all because it's not cost effective to screen them. It's more cost effective to treat everybody. If you have somebody who comes to the United States and has a very low CD4 count, and you know it may be a while until their T cells go up, would you consider treating them for latent TB disease because they come from a high TB incidence country? And we have, in some instances, done that. Yeah.
The danger to treating for even
just medication toxicity. And that's really the danger of anything, is that it would be treatment with isoniazid, which does have some liver toxicity. Otherwise, there is no, I mean, it would be a no-brainer if there was no toxicity. But because there is toxicity, yeah.
Speaking of the liver toxicity, if a patient is over a certain age, would you treat them with, like over 50, would you treat them with INH?
If they were HIV positive, yes, because risk versus benefit there, the benefit far outweighs the risk. So for people who have an indication to be treated for latent TB disease, age is no longer an issue if they have a strong indication. But just in summary, there is no perfect TB test, and you have to interpret them in conjunction with everything else. However, if you find a positive test, and it's a true positive test, you should treat it in HIV positive because the risk always outweighs the benefit. I mean, the benefit always outweighs the risk. All right, I'm just showing this because this whole issue about false positive IGRA assays. This is serial testing that was done in healthcare workers, where they did an IGRA test every month on a bunch of healthcare workers. Okay, the cutoff for a positive is actually here. Of the 48 healthcare workers, 25 of them had tests that each month went up and down. Okay, so what does this tell you? This tells you that this is not a good test for following people serially, because you can look. I mean, look at the sawtooths here. All right, so although an IGRA test is a very good test in some ways, it is not a perfect test, and we still have a lot to learn about it. All right, latent TB regimens. These are the acceptable regimens for treating latent tuberculosis. The traditional regimen is 9 months of isoniazid. 6 months is about 80% as effective as 9 months. The newest regimen is the 12-weekly directly observed therapy regimen of isoniazid and rifapentine. And then the other regimen that we use is rifampin, okay? And all of these are about 60 to 90% effective in preventing risk of tuberculosis. Now, what about in HIV disease? The accepted regimen, the best regimen for HIV disease is INH. INH happens to be one of the things, despite the shortage, for which the CDC guidance still says that this would be a group that preferentially should still get isoniazid. The problem with rifampin is that there are lots of drug interactions with HIV medications. So rifampin for somebody on a lot of our HIV treatments is not as good of an option because of the concern about drug interactions. Rifabutin can be used in some instances instead of rifampin. All right, now the INH plus rifapentine regimen is a very nice regimen. It's 12 weekly doses, has to be given by directly observed therapy. The problem is that there's not much data yet for rifapentine and antiretroviral drug interactions. And therefore, except in the context of a study, it is not recommended for HIV-positive individuals who are on antiretroviral therapy. If you have somebody who you're treating who's not yet on antiretroviral therapy, it would be a consideration. Okay? So let us move on to talk about identifying TB disease. All right, how do we identify TB disease? We go by symptom assessment, and the symptoms of tuberculosis include pulmonary symptoms, which are cough, chest pain, and hemoptysis. as well as systemic symptoms. If you are evaluating people with HIV disease and you just focus on cough, you're going to miss a lot of HIV-infected individuals with tuberculosis. So you want to pay attention to pulmonary and systemic symptoms. There are several different scales that are used, but pretty much if you screen for any of these symptoms within the previous month, you are likely not to miss any cases of tuberculosis. Now, in the United States, there's not that much tuberculosis, so the sensitivity, the specificity is pretty low, but the sensitivity is quite good.
How long does it take to develop symptoms?
It can take, you mean from the time you're infected?
Well, you mentioned if you asked within a month, so I was wondering why.
Oh, that was if they've had these symptoms over the course of the previous month. So if you're evaluating them at a particular time and you want to know if they've had symptoms in the past month. But you can develop symptoms at any time. So, we talked about drug interactions. The major issue with tuberculosis and antiretroviral therapy is drug interactions with rifamycins. It increases the metabolism of these drugs, increases the risk of antiretroviral failure. There are other issues with co-infection. It gets more and more complicated as more and more antiretroviral drugs come out, and I can no longer keep up, and I go to the guidelines when I need to look at a complicated patient and figure out what to do. You basically treat them in other ways the same as people who are HIV negative, except that they sometimes need a longer treatment course, and we strongly recommend directly observed therapy for people who are HIV co-infected for a whole variety of reasons. That would be an indication, even if they're not pulmonary smear positive, to do directly observed therapy until completion of their treatment. Okay? There are some other slides that I'm not going to have a chance to go through. I have 5 more minutes, okay? So just a couple other things that I want to talk about. 2 other issues with HIV and TB co-infection. Back to our first patient from South Africa, who we just found out was HIV positive, and she has a CD4 count of 40. She's getting better on her TB treatment. When do we want to start her on antiretroviral therapy? Okay, so we have a couple of options right away, pretty right away, if not immediate, you know, a little ways down the road, or treat her TB first, okay? I think the guidance now is quite clear on what we should be doing here. There used to be a number of different reasons for why we might consider delaying therapy. One is because it's a lot of drugs, a lot of toxicity. We also worry about immune reconstitution syndrome. When you start people with tuberculosis on antiretroviral therapy, this is when their immune system all of a sudden says, I feel better, and starts to overreact to an infection that may already be present. However, the burden of data now is that you want to start them as soon as possible. There have been a couple of major studies, mostly from other parts of the world, but have shown even at very low CD4 counts, there is a significant mortality difference in people who are started early on antiretroviral therapy with tuberculosis compared to people for whom treatment is delayed. So the newest DHSS guidelines for antiretroviral therapy say everybody should be started on antiretroviral drugs if they're co-infected and on TB therapy. If they have CD4 counts less than 50, you want to get them started on HIV drugs, ideally within 2 weeks. If their CD4 count is greater than 50, but they're pretty sick, you want to get them on treatment within 2 to 4 weeks. If they're not as sick, you can delay, but you definitely want to have them on treatment by 8 to 12 weeks, okay? And if they have multi-drug resistant or extremely drug-resistant disease, you want to get them on antiretroviral therapy as soon as possible because these people are more likely to die from their TB. Okay? And this is the last slide we're going to talk about. So this is our patient. We just started her on antiretroviral therapy. And she started on a regimen of Atripla. Okay? We can talk about whether that's the right thing to do related to her contraceptive age and stuff later on. And then she starts to develop fevers and large, tender cervical lymph nodes. So what should we do about her TB drugs now? What's going on with this lady? All right, so she's been on TB therapy, and she's been doing really well. And we start her antiretroviral therapy, and something seems to be going maybe not wrong. Yeah, this is immune restoration inflammatory syndrome, or IRIS, okay? And it happens to tuberculosis. Globally, tuberculosis is the most common infection that causes it, but many other infections can as well. And it's basically your macrophages going wild, okay? You've started antiretroviral therapy. Your immune system now says, oh, you have this infection I don't like. And your immune system starts to respond to an infection it was pretty much ignoring before. You see it most commonly in people who have very low CD4 counts. When they're started, usually occurs within the first couple of weeks of therapy. And it can either present as worsening disease or clinically worsening disease, or it can present as their disease all of a sudden shows up because you didn't even know it was there. But it doesn't always mean that you're failing therapy. You just have to be aware of it. And some people can get actually quite sick with immune reconstitution syndrome. Rarely, however, do people die from this, okay? But it's important to distinguish this from people who are failing treatment. Usually if their disease is doing very well, and the manifestations are pretty characteristic of swollen glands, things like that, that's very common with IRIS. I mean, but you can't always be absolutely sure. But generally, if people are tolerating their medicine and are on an effective regimen, their TB disease shouldn't get worse. Okay, why don't we stop here? They don't have, the cases burden is not high enough that we don't have a lot of facilities for putting people in. However, individual patients can still be quarantined and incarcerated to get directly observed therapy if they're non-adherent with treatment and deemed to be a public health menace. Now, the local laws regarding this vary in different jurisdictions. The most recent person that we had to deal with was somebody that we had under house arrest with an electronic bracelet so that if he ever left his house, then the police would come. But this is somebody with multi-drug resistant tuberculosis who got on an airplane and tried to leave the country. So there was good public health incentive. I mean, we try as much as possible to work with our clients to make sure that they take their medicines. And we do have lots of resources through the TB programs to ensure that that happens. Yes. Yes, if we're evaluating somebody for active tuberculosis, our tools are chest x-rays, which may not be perfect with HIV disease, as we talked about, and sputum cultures, or if they have disease at a non-pulmonary site, you might sometimes have to do biopsies of other things. If they have big lymph nodes, you might have to biopsy their lymph nodes. But yes, you would collect sputum as part of the evaluation. Okay, so yes, so let's talk about a couple of questions that, all right, so there were a couple of things here that caught my eye related to tuberculosis, and we can talk in relation to HIV as well. But just in terms of tuberculosis, first of all, they say that the mother has a history of tuberculosis? Now that you're all experts, what does that mean? Statistically, the odds are that this would be latent, but not necessarily. And many people can't tell that. Most people are not sophisticated enough to tell you whether or not it's latent or active tuberculosis. So is there anything that you might ask that might help you determine in your own mind whether or not it was latent or active, other than the fact that anybody who's actually treated for active tuberculosis is in a database somewhere, and that information is eventually discoverable? Pardon? You could ask about symptoms or family history, or, yeah, it's probably the single best question. Did you take a handful of pills, or did you take one pill? Right. We generally, until we have single pill therapy for tuberculosis, which we don't, latent TB therapy is usually treatment with a single medication most of the time, whereas active tuberculosis starts with 3 or 4 medications and then continues for at least 2. So if they tell you, yes, I took a bunch of white pills and some red capsules, then they were being treated for active tuberculosis. And if they said, I took 1 pill for X number of months, then they were treated for latent tuberculosis. And most of the time, that's what they had. Yeah. Now, the other question I had here is, so they talk about the clinician who initially saw the patient said, oh, she has a history of tuberculosis. I don't have to worry about her syphilis test. What? The clinician believed this was a biologic false positive due to her past history of tuberculosis. What did people think about that? Well, I mean, there is a long list of things that will give you a false positive RPR, okay? And tuberculosis happens to be one of those things on the list, although I can't recall actually ever having seen tuberculosis, and we don't even know this person had tuberculosis, being a cause of a false positive RPR, all right? However, do these things that give you false positive RPRs give you false positive specific syphilis tests? No, they don't. So, you know, if there is a positive confirmatory test, a positive FTA or a positive VDRL or an MHATP, then that's nonsense. So I'm not exactly sure why the clinician thought that, but obviously you would never think that, right? Right. All right. Now, and I guess, are we worried at all about HIV infection in this woman who recently acquired syphilis? Okay, so what could we do about that, or what should we do about that? Well, that'll treat her syphilis. Now, what's the problem with HIV testing if you tested her at the time that she was diagnosed with syphilis? Pardon? Right. I mean, you may not have a positive test at that point. And so is there anything that you could do differently? If this were a circumstance where you felt that it was imperative to make sure she did not have HIV infection because of the risk to the infant, you can do a direct virologic test, like a viral load, which will be positive earlier than most of the rapid tests that we have. Now, the window is getting shorter for we used to say 6 months. I think with a lot of the newer tests, that window is actually shrinking in terms of time of exposure to time to positivity. But you don't have necessarily the the reliability that a negative HIV test, no in this instance doesn't necessarily mean no.